Hi everyone, thanks again for joining us for this Thursday's Becoming a Doctor tutorial. This one will be on common renal conditions by Dr. Jaye Brunning. And just running through the house rules for everyone who already knows. If you're watching this on the Zoom, if you have any questions or comments about the tutorial itself, from chat, and Jay will get to them once you can. Any questions that might not refer to the tutorial, but you still want to ask that can wait till the end, put them in the Q&A section. And for anyone watching on the Facebook, again, comment, question, we will be answering them as we go along. And off to you, Jay.
Perfect, thank you very much. So my name's Jay and I've just recently graduated from Brighton and Sussex Medical School and I'm due to start work as an F1 in August, and I'm going to talk you through some common renal problems that you might come across today. So what we're going to go through is we're going to kind of have a quick recap of what the kidney does and how it looks, and then we're going to talk a bit about acute kidney injury, chronic kidney disease, and then briefly touch on some renal replacement therapy. So firstly, just to go to an overview of the kidney. When I think about what does the kidney do, I like to split it up into things that it controls, things that it makes, and things that it gets rid of. So in terms of controlling things, the kidney controls acid-base balance, water balance, electrolyte balance, and blood pressure. It produces two things. So it produces erythropoietin, which is the hormone responsible for the formation of new red blood cells. And it also takes the vitamin D that comes from the sun and your diet and activates it into a form that your body is able to use efficiently. And then when I think about what it removes, I kind of generically overarch it into kind of one thing, and that's kind of waste and toxins. And what I mainly mean here for the purpose of this talk is drugs and urea. So just a recap of the brief anatomy of the kidney, it's split up into the cortex and the medulla. I do apologise, this is slightly blurry. And then the urine forms in the nephrons, which kind of can go across here, and then forms down to the ureter, where it heads to the bladder and then leaves the body as urine. The functional unit of the kidney is the nephron, and just a quick recap on what the nephron is and kind of how urine flows through it. Blood enters the glomerulus, which is kind of acts like a big sieve, and then it forms kind of the pre-urine in the Bowman's capsule, then goes through the tubules, down the loop of Henle, and through the tubule before going down to the collecting duct to form urine kind of as it comes out of the body. Lots of processes happen there that I'm not going to touch on because that's kind of preclinical years, but it's just good to remember what the nephron looks like and what kind of happens there in general. So when it comes to clinically measuring kidney function in any sort of hospital or GP setting, there's two things that we look at, and mainly those are creatinine and the estimated glomerular filtration rate. So when we think about creatinine, two things are important to remember. So the first is that one measurement alone doesn't really tell us enough about the patient's kidney to kind of give us a real idea of what's going on. So we need serial measurements to get an idea of what's happening to that patient. Also, creatinine varies with age and muscle mass. So if you have an older, frail lady, she's going to have a much lower baseline creatinine than that of a kind of bodybuilding younger gentleman. When it comes to the estimated glomerular filtration rate, there's many things that determine this because it's done kind of as an estimate, as you can see, by an equation. And the things that go into that equation are creatinine, age, sex, and ethnicity. And that's quite nicely remembered by the acronym CASE that you can have there, because sometimes people can ask you that, and it's good to kind of have an idea of what makes it up before you kind of just interpret it blindly. So we're going to move on to our first case now. Mrs. A is a 64-year-old female who presents to A&E with a 4-day history of diarrhea and vomiting. She has been unable to eat or drink for the past 48 hours. She comments that she's got a decreased urine output over the past 12 hours. And when you examine her, she has dry mucous membranes and reduced skin turgor. So those are kind of markers of decreased fluid status. But luckily for us, her observations are stable. So what you do as the kind of dutiful medical student or junior doctor is you get some investigations for her, and you get her urea and electrolytes so you can work out her creatinine and EGFR. And you get her creatinine result back, and that's at 180, when ideally we'd want it between 50 and 120. And her EGFR is 26, when ideally we'd want that to be over 60. But like I said before, it's really hard to get an idea of what's happening with the patient just with one static view. So luckily for us, our patient last week had some blood tests done, so she's got some urea and electrolytes results from a week ago. And then her creatinine was 85, and her EGFR was over 60, so her kidney function was doing a lot better than it is now. So what we're talking about here is an acute kidney injury, and all we mean by that is an acute decline in kidney function. So when it comes to thinking about acute kidney injury, they like to classify it in terms of stages, 1 being the least bad and 3 being the worst. And the markers that they use to kind of quantify this and stratify this is creatinine versus your baseline, or how much urine output the patient has got. So like I said, 1 is the least bad and 3 is the worst. They're kind of arbitrary numbers. You can remember them if you want to, or just having an idea of how the stages work, because in practice, if someone's at stage 3, we know they need much more immediate attention to do with their kidneys than they do at stage 1. When we think about the causes of acute kidney injury, I like to split it up by anatomical location relative to the kidney. So that's pre-renal, renal and post-renal. So pre-renal means anything before the kidney, renal means anything in the kidney, and post-renal means anything sort of from the ureters or the bladder downwards and the lower renal tract, lower urinary tract, sorry. And that's a good way of thinking about the causes of this. So to go on to the pre-renal causes, what I mean by this is renal hypoperfusion. So the kidneys require 20% of your cardiac output to kind of do their jobs functionally. They get a lot of blood a lot of the time. So if there's something causing you to have a decreased amount of blood flow to your kidneys, they're not going to be able to work as they should be. There's lots of different reasons that the kidneys might be underperfused, so I've got some reasons here that we can split down further. So hypovolemia or hypotension. If a patient's having a massive hemorrhage, they're not going to have as much circulating blood volume, so they're going to have decreased cardiac output going to their kidneys. If a patient has has had an episode of diarrhea and vomiting for a prolonged period and they're not able to take in fluids, they're going to be dehydrated, and similarly that's going to have the same problem. And then osmotic diuresis. So if a patient's got high levels of glucose in their blood, it often gets excreted into the urine. So the urine has a stronger concentration, and water always follows glucose, so you're going to lose fluid that way. So that's kind of what happens in diabetics. Renal vascular changes is the second reason that you might have decreased blood flow to the kidneys. And some of the examples of this are drugs causing vasoconstriction to the kidneys. And namely, the main example that you'd kind of think of when you think of this is non-steroidal, such as ibuprofen or naproxen. And then we have this strange thing called hepatorenal syndrome, can also cause renal vascular changes. So when a patient has a problem with their liver, so a cirrhotic liver, often their fluid goes into spaces it shouldn't be. So what it simply means is that the kidney is not getting the fluid because it's somewhere kind of in their ascites and not going to where it should be. It's not in the right place. And then finally, we're talking about redistributive shock. So those are the kind of cytokine storms that we're talking about. Peripheral vasodilation, meaning the blood is pooling elsewhere as to where we want it to be. And some of the causes for that are sepsis, which is incredibly common, anaphylaxis, or decreased oncotic pressure. And what causes that is a loss of protein. Common conditions that cause that are kind of congestive cardiac failure, or again, cirrhotic liver in someone with chronic liver disease. So that's the pre-renal causes. And now we go on to talk about renal causes. And what I mean by this is damage to the kidneys themselves. When we think about these, we can further subdivide them into anatomical categories again. So we can have problems with the tubules, or we can have problems with the glomerulus, or we can have problems with the space between the tubules themselves. So when we think about acute tubular necrosis, so that's of the tubules, what happens is if someone has a prolonged hypoperfusion to the kidneys for a really long time, they're not going to, the kidneys aren't going to get enough volume for them to work as they should, and eventually the tubes can become necrotic. So when someone says acute tubular necrosis, all they mean is that they've got a progression from a renal cause, a pre-renal cause. Secondly, we're talking about interstitial nephritis. So that's inflammation of in between the tubules. And the things we're talking about here when we think about this are damage from drugs, such as, again, NSAIDs, ACE inhibitors, so those are your blood pressure medications, such as ramipril, so they have the ending pro, or antibiotics, particularly the aminoglycosides such as gentamicin. And if any of you have ever kind of had a look at a drug chart, often gentamicin is prescribed in a separate area because you need to make sure that you're checking the patient's kidney function before you give them several doses, because you don't want to cause them any problems when you're trying to make them feel better. And then thirdly, we're talking about glomerular damage, and that's kind of the big scary thing of glomerular nephritis, which I will slightly touch on now, but not in full enough detail kind of to be comprehensive entirely. So what do we mean by glomerulonephritis? So basically it's inflammation of the glomerulus, which leads to leaking of protein, and sometimes that protein is also accompanied by blood. There are many different causes for this. There's many different reasons why patients might have glomerulonephritis, and this kind of term is an umbrella term for a spectrum of diseases that present as two different syndromes, and these syndromes are called nephrotic and nephritic syndrome. So just a little bit about nephrotic syndrome. It's got a classical triad of the three big bullet points there. So proteinuria, edema, and hypoalbuminemia. So the patients are going to be losing a lot of protein in their urine, which is going to mean that they're going to have on their urine dip a really high number of proteins, and they might report that their urine is frothy. They're going to be edematous, so they're going to have fluid, because they've got that decreased oncotic pressure that we were talking about earlier. They're going to have fluid kind of on their legs, they're going to have leg swelling, or they're going to be short of breath because they've got fluid on their lungs. And then when you take their measurement of the protein in their blood, albumin is a protein in the blood, it's less than it should be. And then the other side of the coin kind of is nephritic syndrome, and that's where you're losing blood as the primary factor. There will be a little bit of protein loss and a little bit of edema, but there'll be much less so than nephrotic syndrome, and the patients will be hypertensive and they'll have a lower urine output than you would expect of them. So what I would recommend is that you go and look up some of the different causes, especially kind of if you're further in to sort of 5th year, as to why patients do get glomerulonephritis, because there's a lot of different diseases, but in a kind of umbrella term, they cause these two syndromes. So that's what you get as your presenting complaint, is someone presenting as either of these. So moving on to the post-renal causes of acute kidney injury. What we're talking about here is obstruction to the flow of urine. So we can split that up into within the upper tract, outside of the upper tract, and to the lower renal tract. So when we think about within the upper tract, we're thinking about stones. So that's your classical history of a patient that's got kind of renal colic pain. So that's kind of back or flank pain that is intermittent but really severe. So they'll be rolling around on the floor 1 minute and then the next minute they'll be absolutely fine. That, or you can have a malignancy which presses down onto the ureters, blocking them, and if that's within the upper tract, we tend to be thinking about kind of renal cell carcinomas then. When we think about outside of the upper tract, the abdominal cavity is really busy and there's lots of stuff in there, so there's many things that could press on there. So any kind of malignancy within the abdominal cavity, if it was in the right location and grew big enough, could put pressure on the ureters to mean that the urine couldn't get out. It would backflow up and it would cause a problem with our kidneys. Retroperitoneal fibrosis is a condition that causes a similar effect of kind of pinching on the ureters. You can have a look into it if you want, but just know that it can cause a post-renal acute kidney injury. And then when we're thinking about the lower renal tract, we're mainly thinking about prostate, so that's kind of your older gentleman with the symptoms of prostatic disease. So here we're thinking nocturia, terminal dribbling, hesitancy, and increased urgency. You might also get a patient that's got bulky kind of uterine disease from malignancy that could press on the lower ureters, and that could give a similar effect of causing a problem with kidneys. Or we could also think about patients that have a reason for having a catheter in, and if that becomes blocked, they're not going to be able to get their urine out either. So what do? We've got all of these causes and we kind of now have to stratify how this is working and what's causing our problem, because we know that we've got a dip in kidney function. So a really simple tool in kind of renal and urology is a urine dipstick. So if we see protein and blood, then we often think of renal causes. So those are our interstitial nephritis, acute tubular necrosis, and glomerulonephritis. And again, it's really important to quantify how much protein, because when we're thinking about those nephrotic and nephritic syndromes, it does really differentiate and help the renal doctors to treat the patient the best they can. We can do some bloods as well. Liver function if you're worried about hepatorenal syndrome, but that's quite rare unless you're in the gastro ward, where there's plenty of patients with cirrhosis. And then you can also do these bloods to investigate for specific causes. These are a lot of different antibodies that kind of indicate towards rheumatological disease. I'm not going to go into them now because there's lots and lots of them, and I think they're best placed within a rheumatological lecture, but I think it's good to know that you should have a look at some systemic diseases that have these specific antibodies, and here's some of them here. And then we finally want to do an ultrasound scan of the kidneys, and what we want to do there is get a kind of map of the kidneys. We want to know whether or not they're symmetrical and how big they are, because if a kidney is less than 9 centimetres, typically that's more likely to indicate a chronic problem than it is an acute one. Not always, but that's typically the way it is. And ultrasound is also really good for looking at to see if there's any obstruction and whether or not you need to call the urology doctors. So how are we going to treat these patients that come in with this AKI? Because there's numerous causes, and the classic phrase in medicine is to kind of treat the underlying cause. I've tried to split it up simply. Each condition has its own way of treating it, but generically you can kind of group them together. So firstly, we're thinking about the pre-renal causes, and again, that was that renal hypoperfusion. So what we're trying to do there is get the blood flow back to the kidneys. And what we're thinking about there is kind of giving that patient some more fluid. Also, if a patient is septic, the reason I thought I'd include this is because sepsis is really common within medical school exams, and it's really something that you do have to kind of know on the tip of your tongue. So you might want to do the sepsis 6, which I've written out here. I use the acronym BUFFALO. Some people like give 3, take 3, but I'd have a look if you're not sure, because it definitely is something that by the end of medical school, kind of even your earlier clinical years, that they kind of do want you to have an idea on. I'm aware that there's some questions. What I'll do is I'll answer them after the acute kidney injury stage while you're having a look through the pulse, so I haven't forgotten about them. So then on to treating the renal causes. Often what we mean by that is kind of call the renal doctors. If there's something going wrong intrinsically in the kidney, they're typically the best place to be able to solve it. You also want to stop any offending agents. So if you've given them gentamicin, you don't want to be giving them any more gentamicin if that's what's caused the problem with their kidney. And you might want to modulate their immune system, for example, in those autoimmune diseases that cause glomerulonephritis. Steroids is often a good place to start for that, as it does dampen down your immune system. And then for the post-renal causes, what we want to do here is stop that obstruction. So if it's a patient with prostate problems, you might want to think about catheterizing them in the interim so they can get that urine out, and then thinking about treatments such as alpha blockers or things like finasteride later down the line to get that swelling down so that they are able to pass urine in the future. And if we've got stones, that's kind of, like I said, the territory of the urological doctors, but there's lots of different things they can do. The first is extracorporeal shockwave lithotripsy, which is where they blast the stones with shockwaves, and it breaks them down so the patient can pee them out easily. Slightly more invasive is stenting. So that again is inserted into the ureters to enable the patient to pass stones more easily. And if the patient is acutely sick and the urine is backing up to the kidneys and making the kidneys big, which is called hydronephrosis, they might need something which is called a nephrostomy. And what that is insertion of kind of a catheter through the skin into the back so that the urine can drain immediately. And that's normally a temporizing measure until we can treat the underlying cause. But that's a good way of kind of getting things done quickly. And then we also have to think about things we could be doing to the patient while their kidneys are bad that could be making their kidneys worse. So these aren't necessarily the causative things, but it could be that we're not helping the situation by things that we're doing. So what I'm thinking about here is any drugs that might be offending agents of making their kidneys worse. And the mnemonic for this is stop the damn drugs. So we mean diuretics, ACE inhibitors, metformin, and NSAIDs. And the reason I've got lactic acidosis next to metformin, I'll explain now. So when we think about stopping drugs in someone that's got an acute kidney injury, we either do it because firstly that they're having that direct effect on the kidney which is negative to the kidney, or secondly it's because the drug is excreted through the kidneys and it will accumulate if you don't decrease the dose or sort it out, which could lead to problems for the patient. For example, one of the bad side effects of metformin is that you get lactic acidosis. If the kidneys aren't excreting the metformin as they should, then you're much more at risk of this, so your patient will be much sicker, and that's why you stop metformin. I've got that a bit later in the slide, so if that didn't make sense, hopefully I'll be able to patch it up then. And the second thing is that we often like to scan patients in hospital because we like to know what's making them bad, and scans help us do that. But when you give some CTs or MRIs, often a contrast is given. and contrast isn't very good for the kidneys. So if your patient has an eGFR of less than 30, you typically don't want to just off the bat give them contrast because it could make them a lot worse. This is not necessarily a decision that's a lower level, whether or not the scan is beneficial or weighs the pros or cons, but the consultants will make decisions as to whether or not they think that this scan is necessary and worth the risk to the kidney. But what you can do is you can rehydrate the patient before and after the scan to try and minimise that damage. So if we are ready to go back to our case now, I'm going to read it out to you because on the poll I've just got the answers. So if you pay a bit of attention to what it says in the question, then it's not going to come up when I put the poll up. So Mrs. A is a 64-year-old female who presents to A&E with a 4-day history of diarrhea and vomiting. She has been unable to eat or drink for the past 48 hours. She comments that she has a decreased urine output over the past 12 hours. On examination, she has dry mucous membranes and a reduced skin turgor. Her observations are stable and her urine dip is normal. Her eGFR is now 26 when it was over 60 last week. So what is the likely cause of her acute kidney injury? So I'm going to release the polls now because you'll be able to see the answers there. 1 minute, sorry. There we go, so that should be up now for you to be able to do if you'd like. So just wait another second while a few more people answer if they want to. Okay, it's kind of slowed down a little bit there, so what I'll do is I'll end the poll and release the poll. Lovely, so the main answer that people got here is dehydration, and I would agree that that is the correct answer. We've got that classical history of diarrhea and vomiting, which leads us to think that she is dehydrated. Secondly, she's got those kind of markers of decreased fluid status, so that kind of reduced skin turgor and dry mucous membranes. So we like that one, we think that works fairly well. Some people put interstitial nephritis. The reason I don't think that this is because there's no kind of real mention of any kind of offending agents within the stem. So typically it would be the patient has started taking NSAIDs, say, for example, for her joint pain. There's none of that there, so it doesn't necessarily make me think that at the time is the cause of this. And then we've got another one for glomerulonephritis. Her urine dip would either have a lot of protein and no blood, or some protein and some blood. So that makes us think it's not glomerulonephritis. The reason I don't think it's renal stones is because we've got no history of renal stones. And the reason I don't think it's sepsis is because her observations are stable, and often these patients are really sick and particularly are hemodynamically unstable. Okay, so I'm going to stop sharing those results now and we'll move on to, we've got another case. So that's the answer, dehydration. So if you want to have a look at it later, that'll be up there for you. So on to case 2. Mr. B is a 76-year-old male who presents to the hospital as he has not passed urine in 24 hours. He states that for the past 6 months, he has noticed he has an increased urinary frequency, terminal dribbling, nocturia, and urinary hesitancy. The urine dip is normal. And the question again is, what is the likely cause of his decline in kidney function? So I'll just get the poll up and running. You can have a quick read of that if I read that too quickly. Lovely, so I'm going to launch that poll now. Feel free to take part if you want to. Wonderful, so that started to slow down a little bit there, so I'll just end that poll. So the options here were glomerulonephritis. I don't think it's this. Again, the urine dip is normal. We don't expect to see that. Hepatorenal syndrome, there is no mention of any kind of stigmata or signs of chronic liver disease. That's kind of your spider nevi, caput medusa. Jaundice perhaps, that's none of that there. Interstitial nephritis, again, no offending agents. Renal stones, no history of renal colic, and so that kind of pain, so I don't think it's that. And yeah, this sounds exactly like a prostate problem. So when we think about those kind of increase in urinary frequency, terminal dribbling, we think, okay, this is someone with a prostate problem. So that is the most likely cause in this patient. So well done. Okay, and sorry. So case 3. Mrs. X is a 54-year-old female who's been in hospital for 3 days post-cholecystectomy. The F1 notes that she has a rise in creatinine from 92 to 192. So she's had a rise in creatinine of 100 and her eGFR is now 30. So the question I'm asking here is which one of Mrs. X's on-admissions medicines should be stopped? The options are ramipril, paracetamol, gabapentin, Movicol and citalopram, and I'm going to release this poll now. Give you a chance to answer it. Okay, so a lot of you have answered there, so I'll end poll and release the results. Lovely, so the most common answer there is ramipril. That's an ACE inhibitor, so that's one of our stop the dam drugs. That's diuretics, ACE inhibitors or angiotensin receptor blockers, metformin and NSAID, so that makes perfect sense. We should stop that because she's definitely got an acute kidney injury at this point. Paracetamol, no one picked. It's not classically, we worry about it in kind of liver problems, but not necessarily in kidney problems. And then gabapentin, Movicol and citalopram. These might have to be adjusted if the creatinine gets really low, but they don't have to be stopped necessarily in acute kidney injury, depending on what the eGFR is. So for example, citalopram needs to be at a reduced dose when the patient has an eGFR of 20, less than 20. But that's not going to be making this AKI worse at this immediate time. So we don't need to stop that drug. We just might need to check in the BNF to see if we need to dose adjust to the other drugs. Okay, so I'm going to now have just before I move on to my next section, because that's all done for acute kidney injury, I'm just going to see if there's any questions in the chat that I can answer. Okay, so what were the factors that affect estimated glomerular filtration rate? Again, that is on the slide, so you can have a look later, but I'll just quickly recap. The acronym is CASE, so we're talking about creatinine, age, sex, and ethnicity. Hopefully that answers that one for you. With water always following glucose in the diabetic presentation mentioned, what happens to sodium? That is a very good question. My homeostasis of electrolytes is not necessarily tip-top, and there's lots of complex different pathways that happen. I think classically, I know that the reason they get dehydrated is because they're urinating out the sugar, and that follows the water. You'd have to kind of recap from a kind of preclinical textbook as to what happens with the specific transporters at specific points of the kidney, because I'm not particularly sure, so I do apologise. And hi, sorry, what systemic disorder with acute with anti-mitochondrial antibody causes an AKI? Typically, anti-mitochondrial antibody is related to primary sclerosing cholangitis. No, biliary cirrhosis, sorry. I'm not particularly sure specifically, but when I looked up from my documents, I'll put my references at the end so you can see, AMA was one of them. Not all the antibodies are particularly specific or sensitive. They vary in those, so it might become positive in a different one as well, so I do apologise, I can't answer that one either. Okay, so I'm going to move on to our second section now. We're going to start with a case. So Mr. L is a Mrs. L, I guess, is a 62-year-old female who presents to her GP complaining of itching and fatigue that has been worsening over the past year. Upon examination, she has a yellow tinge to her skin and a raised blood pressure. The GP sends her for some investigations and her eGFR is 15. 6 months ago, it was 21. So what we're talking about here is a kind of chronic low kidney function. So naturally, that's called chronic kidney disease. So what is chronic kidney disease? It's an abnormal kidney structure or function that lasts for over 3 months. And before we were talking about eGFR and creatinine. Here, when we're trying to classify chronic kidney disease, we're talking about eGFR and the amount of albumin in the urine or albuminuria. And that's because the reason we're talking about albumin here is because it's really prevalent in the blood, and it shouldn't be excreted by the kidneys, it should be retained. But if there's damage to the kidney or the nephron, then some escapes and it gets to the urine, and that is kind of a marker for how bad kidney disease is. So this is how we split up chronic kidney disease based on EGFR. I'm not going to go through it all, just a couple of things important to note are that it gets worse the higher the number is. So stage 1 is less bad and stage 5 is kidney failure. Stage 1 and 2, which is an EGFR of between 60 to over 90, are only called chronic kidney disease if there's evidence of damage present, so that be that kind of blood or protein in the urine, or a symptomatic patient. And yeah, it's important to kind of know that kidney failure happens when the EGFR is less than 15. When it comes to albumin, again, the higher the number, the worse it is. And there's 2 ways that you can measure albumin in the urine. The first is the albumin excretion in milligrams over 24 hours. This classically is not done particularly anymore because it means that the patient does have to give a true reading of 24 hours worth of urine. So you can imagine if you're kind of not just sat in your house, it'd be quite difficult to kind of collect your urine for the day to be able to take it to the lab to be kind of investigated. So what they tend to do now is albumin to creatinine ratio in the urine, and basically what you kind of have to know is that the higher these numbers are, the worse off it is. So the more albumin, the worse the kidney is. And why does this matter? So these factors are prognostic, so they allow doctors to kind of give a patient an idea of how bad their situation and what kind of trajectory is going forward. Low EGFR and albuminuria are associated with an increased risk of, firstly, all-cause mortality. They get more risk of kind of progressing further down their chronic kidney disease and getting renal failure. They're also more likely to get acute kidney injury if something goes wrong with their health in the interim. And the most important thing is that they're 20 times more at risk of cardiovascular mortality. So that's why it's really important to pick up these patients and make sure that you're doing everything that you can for them before they kind of get an issue with their cardiovascular health. And I thought it was quite shocking that patients are far more likely to die from cardiovascular disease than they are to need renal replacement therapy. This is just a table that is published kind of showing the data for what I just said. So here we have high albumin, low EGFR, and that's really high risk. And again, a higher EGFR, low albumin is a better risk. So that's talking about all-cause risk there. So what are the causes? So there are many, many different causes that can cause chronic kidney disease, and these can either be a problem with the kidney themselves or a systemic disease that then affects the kidney also. So I just thought, rather than list them all, you can have them a look up later if you'd like to. But in the UK, the commonest causes are, firstly, number 1 by far is diabetes. It's one of the macrovascular complications that you will have learned about in kind of your diabetes endocrinology lectures. And it's really common, so this is why chronic kidney disease is a big problem, especially people living longer with diabetes. Second is glomerulonephritis, and I know I said that was a cause of acute kidney injury, but if that's not treated at the time, it can progress to having problems chronically with the kidneys, and some of the diseases that cause it have a worse prognosis in heading towards renal failure. And third is hypertension or renovascular disease. So again, really common. If you've been to a GP placement, you'll have seen lots of people that come in for blood pressure reviews, so it's important to catch these people early, and this is why we want to make sure we control people's blood pressure at kind of the point we notice it's high. One thing I didn't put on the slide, but you might want to have a look at, is polycystic kidney disease. Often it can come up in medical school exams because it is an inherited disorder and it has a strong association with subarachnoid hemorrhage. So just have a little look into that if you wanted to, but I just wanted to focus on the common causes. So what are the symptoms? Patients are often asymptomatic, or they come in with really kind of general non-specific symptoms. So patients can be symptomatic at around an EGFR of 30, less than 30, which is really low. So they can be kind of rumbling along well enough while the kidney function is declining. The main symptom people kind of present with is fatigue. They might also report that they kind of have a decreased appetite and feel a bit nauseous. They might say that they're fluid overloaded. They might say they have rested legs, or that they feel weak, or they feel itchy. And it's important to note that patients might not present until they've reached the point of needing renal replacement therapy, which is pretty scary to think that you can think you're okay and then all of a sudden need to be on dialysis, so which I'll talk about later. When I like to think about the symptoms a patient might present with due to the complications of kidney disease, I like to think back to those the functions of the kidney that we talked about earlier. So that's the controls for, removes one, produces two. And I'll go through those now. So the kidneys balance blood pressure. So hypertension is both a cause and complication of chronic kidney disease. And once your kidneys are responsible for the renin, angiotensin or aldosterone system. So once the kidneys have been damaged, they are less able to regulate your blood pressure, and that also then further increases your risk of cardiovascular complications. And like I said before, that's a huge risk in these patients. So we need to make sure we get a handle on the blood pressure, which I'll talk about how you do later. When it comes to electrolyte balance, the kidneys normally excrete phosphate and potassium quite heavily, so patients are at risk of accumulating these, so they might become hyperkalemic, and that is bad because that can lead to kind of very life-threatening arrhythmias, and they might have high phosphate, which alongside something to do with calcium, which we'll talk about later, can cause problems with their bones. So the way that they treat that is kind of a strict dietary advice. So the classical thing that you'll hear is that patients shouldn't eat bananas because bananas are really high in potassium, and if it gets further down the line and that those dietary advices aren't working and you're worried about patients' electrolytes, that is one of the indications that you might need renal replacement therapy. When it comes to thinking about acid-base balance, patients are more risk of not getting rid of their hydrogen ions and getting rid of more bicarbonate, so they might be at risk of acidosis, which can make them acutely unwell. Eventually they may need treatment with sodium bicarbonate, or they might need renal replacement therapy. And then finally, in the controls balances section, we've got the final thing, which is water balance. So if the patients can't get rid of their fluids, they're going to retain it, and that's going to give them the symptoms of fluid overload. So those are shortness of breath and paroxysmal nocturnal dyspnea, which is where patients wake up in the middle of the night and kind of run to their window because they feel like they can't catch their breath. And those are symptoms of fluid in the lungs. And then patients will complain that they've got kind of big swollen legs that get better when they're raising them, so sort of in bed, and that's because they've got fluid peripherally. So how do you treat this? You would fluid and sodium restrict, so water follows sodium, so the less sodium in the diet, the better in terms of reabsorbing water. And some of these patients can be on kind of less than 1.5 litres of fluid, which is not very much at all. So trying to get them to see why they have to adhere to this, because it will make their symptoms better, is really important. And eventually, if that's not working, then they might need some sort of medical management in form of diuretics. But diuretics have a direct impact on the kidney, so that can kind of muck things up. So they need careful monitoring under the under the watchful eye of the renal doctors. So when we think about removing toxins and waste, firstly we think about kind of the drugs that we might put into patients. So it's really important that we're careful, like I said before, on prescribing in those with renal disease. And either that is, like I said, because they directly impact the kidneys, so they have a direct effect on the kidneys, such as NSAIDs, ACE inhibitors or diuretics, or because they're renally excreted and will accumulate. I already mentioned metformin, another really big class of drug that you need to worry about in patients with kidney disease is opiates. So when you're prescribing morphine, sometimes that's a really bad idea in patients with kidney disease. So just be careful. And if you're in doubt, always check the BNF. There's no shame in making sure you're safe, even if it does take a little bit longer. And then the second thing is the body should get rid of urea, and in the kidneys, if the kidneys aren't working, they won't excrete urea properly, and this will cause patients to mainly complain of pruritus or itchy skin. If their EGFR is low, the urea can actually accumulate and cause problems elsewhere. So they might have uremic encephalopathy, which is where patients report that they, well, they don't report it, they kind of get a change in mental status, and they will kind of get a similar thing to a liver flap. That's kind of good where your collaterals come in. or they might complain of pericarditis, which is that classical history of pain that is worse on lying down and better on lying forward. They might also describe a yellow tinge to their skin, or something that's called a uremic frost, which is where there's kind of a thin crystalline cover over the skin. So those are what happens if you can't remove the things you need to. And then in terms of what the kidney makes, what happens if you can't make those. So erythropoietin, again, is the hormone responsible for making new red blood cells. So if you can't make new red blood cells, it makes sense that you become anemic. And the type of anemia that you'd see on the blood film is normochromic and normocytic, typically, that kind of anemia of chronic disease. But it's really important to treat or investigate for other causes. So treating a patient with EPO is quite expensive and timely. So you want to make sure you're doing the right thing. So you want to make sure that their iron, folate and B12 levels are fine. And you want to make sure there's no kind of that history of maybe a GI malignancy that's quietly rumbling away, losing blood, just because you don't want to miss anything like that before kind of thinking, you know, what's going on. And it's important to know that EPO is iron driven. So if someone's iron stores are depleted, they might need to get those replenished before you give them EPO. And the reason you do it is because they have a low hemoglobin, or because they can't, the symptoms are impacting their quality of life. And those symptoms are kind of tiredness, shortness of breath, particularly on exertion, particularly on uphills. So then on to the final thing that the kidneys make in terms of for this presentation. They activate vitamin D into the form of 1,125 dihydroxy vitamin D. So what this does normally is it causes calcium absorption from the gastrointestinal system. So if you don't have this activated vitamin D, you get decreased calcium absorption from your diet. And earlier we mentioned that there was a high phosphate because you weren't excreting it as much as you should be. There's also a low calcium. And what this combination of high phosphate and low calcium cause patients to secrete parathyroid hormone, and then parathyroid hormone tries to get the calcium level back up by releasing it from the bones, and that's called secondary hyperparathyroidism. And this can lead to patients getting bone pain. So it's quite a good idea to kind of have a grip on your calcium homeostasis here. I haven't gone into it too much, but that's kind of the generic way you need to know for the kidneys at a simple level. So what would we do? What do we need to look at? So when we think about investigating these patients with chronic kidney disease, we're firstly trying to think about, are we looking for a cause, or are we looking for a complication that might encourage you to the fact that their kidneys aren't working quite so well? So in a blood test, you want to check their EGFR and their creatinine. You want to see if they're anemic because they're not making enough EPO. You want to check their glucose to see if they're diabetic, and that might be one of the reasons that they have a problem with their kidneys. And then you want to check their calcium, phosphate and parathyroid hormone to check for those bone problems. The fancy name for that is renal osteodystrophy, if you want to have a further look into that. And then you also again want to look for the reasons for their intrinsic renal disease. Those are a few of the antibodies, again, the rheumatological conditions typically that you can have a look up if you want to. Urine, you want to dipstick it because you want to see if there's protein in there. Again, I said protein was prognostic, so it's good, a quick, easy way to see if there is anything, any protein in there before getting it off to the lab for the albumin and creatinine ratio. You might also want to do a microscopy culture and sensitivity to see if there is any low-lying infection the patient didn't realise that might be a cause. And then Bence-Jones protein is something that you look for in myeloma. Myeloma is a form of blood cancer that can cause you to have problems with your kidney and raise your creatinine. So that's often good to rule out in a patient with an extremely high creatinine, and signs that you might indicate you towards thinking about myeloma as a diagnosis. In terms of imaging, again, we would like to ultrasound the kidneys because we want to map them. Like I said, if it's less than 9 centimetres, that kind of indicates chronicity. Not always. Sometimes some of the causes that make you have chronic kidney disease will make your kidney big, but for the most part, small equals chronic. And you also want to exclude obstruction to make sure that's not the reason. And then we want to do some histology. So renal physicians love a biopsy because that lets them see what's going on. And the reasons you might want to do that is if you're thinking there's some sort of glomerulonephritis, so they can check out what the cause of that glomerulonephritis is, if the patient has systemic symptoms, or if they're just simply not recovering when you think they should be. So now on to management. So we're not too far off chronic kidney disease here. We can split it into slowing progression or managing complications. So we've touched briefly on some of the complications. Once I get to the end of the section, I will answer some of the questions that have come through on the chat, and then I'll go through to the Q&A ones later at the end. So in terms of slowing progression, we always like to split it in medicine into kind of your conservative and then your medical. So our conservative here is diet, be it those restrictions that we mentioned earlier of kind of potassium, sodium or fluid restriction. And you also want to make sure that they have low cholesterol, because again, they're at high risk of cardiovascular mortality. You want to make sure they're staying fit and healthy with reasonable exercise as per the guidelines. And if they are smoking, that will increase their cardiovascular risk even further. So you need to get them in touch with some smoking cessation nurses in order to try and help them to quit their smoking. Then we need to manage their diabetes. So HbA1c is a marker, kind of a long-term marker of what your blood sugar is doing. So a kind of BM or a finger prick or a lab glucose is kind of a one-stop snapshot of what that blood sugar is doing. But HbA1c lets people see how it's been doing over the last 3 months or the life of a red blood cell. And you want the patients here to have a HbA1c of approximately 53, or in old money, 7%. This is slightly higher than is needed for a diagnosis of diabetes. The reason is because the risk, lowering blood sugar comes with the side effects of the drugs, and you don't want to risk the patient becoming hypoglycemic. So that's the target they've decided for people with renal disease. You also want to target their blood pressure. So less than 140/90, or in a diabetic, again, that risk of cardiovascular mortality is that much higher. You want it to be less than 130. Again, you don't want it to be super low because there are risks of being hypotensive. You can get falls, particularly in the elderly. And because the kidney has the RAS system, so renin, angiotensin, aldosterone system, you offer an ACE inhibitor to target this. It can be slightly confusing because I've just said that ACE inhibitors are bad in acute kidney injury, and then we're offering them out kind of to patients with chronic kidney disease. The reason behind this is because the ACE inhibitors have an effect on the renal vasculature, which is beneficial in those with chronic kidney disease, and kind of negative in acute kidney injury because it stops the kidney kind of doing its compensation mechanisms. But just simply try and remember good in AKI, good in chronic kidney disease and bad in AKI. One of the side effects of ACE inhibitors is that they will raise your potassium. So you do have to make sure you're taking measurements of potassium, because you don't want those patients who are already at risk of hyperkalemia. You don't want to make it any worse. And then in terms of preventing cardiovascular disease, this is similar to kind of your patients that have had a heart attack or have a high Q risk, so you think they've got a high cardiovascular mortality. So give an antiplatelet to reduce the risk of atherosclerotic events. This is always kind of the decision to blood, whether or not to thin blood is up to a higher level kind of doctor, because you need to consider that there's a bleeding risk as well. It's never quite as simple as just pop someone on aspirin, but it generally is a good idea if they haven't got any contraindications. And then statins, be that as primary or secondary prevention for cardiovascular disease. One thing that's really important to note in the kind of clinical environment, particularly in A&E medicine, is that if a patient has diseased kidneys, both BNP and troponin, which are proteins for kind of BNP is for heart failure and troponin is for heart attacks, if the kidney's not working, they don't get excreted as well, so they accumulate in the blood. So these patients might get falsely high readings. So it's always with a pinch of salt that you interpret these levels in a patient that has kidney problems. When to refer to renal, I'm not going to particularly go through the slide. I just thought I'd put it in there if you wanted to know. That's that both there for CKD and AKI. You can have a look at it later if you'd like to. So just go back to our case, and then I will answer some questions. So Mrs. L is a 62-year-old female who presents to her GP complaining of itching and fatigue for the past year. On examination, she has a yellow tinge to her skin and a raised blood pressure. Her GP sends her for some investigations. Her eGFR is 15 when 6 months ago it was 21. And the question I'm asking here is, which complication of CKD is most likely to have caused her pruritus? So what I'll do is I'll release the poll now. Sorry. Okay, so that should be coming up on your screens now, so feel free to answer that if you'd like to. Like I said, I'll go through any questions on the chat just after this case, before moving on to the final section, which is renal replacement therapy. So a lot of you have voted there, so I'm going to end the poll and share results and talk you through them. So which is the complication? Most people said that it was uremia, and this is correct. The classical history is that pruritus, and that yellow tinge to the skin, or if someone else was to put kind of uremic frost, is that classical indicator that uremia is the answer you're after. Hypokalemia would present as an arrhythmia or a funny beat in the chest, or it would be something on the ECG. Low vitamin D would be kind of due to bone pain. Someone's put metabolic acidosis. That is kind of a good answer, but the reason that I don't think it is in this setting is firstly that she's in general practice. Patients that are acidotic are fairly sick, and it would have something about her being either hemodynamically unstable or having a high lactate, or her having a low oxygen saturations, that kind of thing, or breathing really fast to try and get rid of CO2. And then fluid overload could have been an answer because it can cause pruritus, but classically she'd also be short of breath, or she'd have swelling in the legs or something like that. Okay, so that was good. I'm just going to answer any questions that there are now in the chat kind of on chronic kidney disease. If there's anything about acute kidney injury, I'll come back to it at the end. One of them is, can we access recordings of these lectures? I'm sure they will be put up. So I don't know particularly where, but I'm sure there will be some somewhere. And the Becoming a Doctor team will be able to give you more information on that. How soon after an AKI can a patient be restarted? Patient with CKD be restarted on that ACE inhibitor? Would you start them on an alternative antihypertensive when recovering from an AKI, e.g. a calcium channel blocker? So good question. I'm not sure of the exact time. I think it depends on the kind of whether or not they've got back to their baseline. Sometimes in patients with chronic kidney disease, an acute kidney injury does lower that much more and does worsen their kind of prognosis. What's important to remember is that treatment for antihypertensives in a non-acute antihypertensive crisis is a kind of prophylactic preventative treatment, and the reason that you're doing it is because you want to reduce someone's risk in the long term. So it would be a higher level decision as to whether or not you switch the drug, but typically they don't need to be on them every second of every day. It's kind of a long-term accumulative benefit of being on them for life rather than being on it for that day. But like I said, it would be probably down to the physicians whether or not they thought it was important for that patient to be on one. So hopefully that answered that question. So does the albumin creatinine ratio look at albumin leakage through the basement membrane from Facebook? Yeah, that's exactly what it does. It lets you know how much is leaking out when it shouldn't be leaking out at all. So yeah, you got that completely right. Is there a specific diuretic indicated for chronic kidney disease which is most beneficial for symptom management? I'm sure there is, but I'm not particularly sure of it. When it comes to a drug problem that I'm not aware of, I always head to the BNF, so I think that would probably be your best source, or heading from textbooks there. I do apologise, I don't have the answer for that one. And then the Becoming a Doctor team have said that they will be uploaded to the Facebook page soon, so that's good. Okay, I haven't forgotten about the people in the question and answer section. I will come back to you shortly. I'm just going to move on to the final section, which is renal replacement therapy now, so people can leave if they want to after that. So the answer to that was uremia. So on to renal replacement therapy, and kind of what I mean by this is dialysis, really. So what is dialysis? It's kind of where you use something else to replace the function of the kidneys when the kidneys aren't working, and I'll explain types a bit more later. So the need for dialysis is usually when the patient's estimated glomerular filtration rate is quite low, so 5 to 10, so definitely in that renal failure category. Patient progression varies, but typically there is a bit of warning before it gets to the point where it's needed. So patients should be prepped for dialysis well in advance of needing it, and it shouldn't have to be a one-off decision that you make then and there unless it's in an acute setting. So in those with chronic kidney disease, it should be something that's been talked about first. So I put the indications there, and classically they're the things that we talked again that are when the kidney is not functioning properly. So when you think back to those controls for makes 2, removes 1, if those aren't working, then that's typically when you would do them if they're refractory to medical treatment. And the two main methods are hemodialysis and peritoneal dialysis. So bit of a busy slide. I have got a picture of hemodialysis and the next one, so it is going to come up, don't worry. Typically, dialysis uses a semi-permeable membrane and a dialysis fluid to transfer, to kind of get rid of the electrolytes and fluid that you don't want in your blood because they shouldn't be there, the kidney should have got rid of them. And that's kind of how dialysis works. And in hemodialysis, this is done outside of the body in a machine. And a semi-permeable membrane allows exchange from blood to a dialysis fluid. So solutes such as electrolytes are removed via a concentration gradient, and fluid removed from fluid is removed via a hydrostatic gradient. And classically, that fluid being removed is called ultrafiltration. So if you ever hear that, then that's just what they mean. One of the problems with this is access. You need a really good source of getting blood out of a patient because this needs to happen for quite a long time, quite often. So the preferred access is via a arteriovenous fistula, and that is something that is done by the vascular surgeons. And you've got a picture of it here. So they put an artery next to a vein that causes the vein to dilate and get kind of arterial pressure within it, and it means that you've got a constant source of a really good way of getting blood out from these patients so that they can get their kind of dialysis. Really important to note, these arteriovenous fistulas are precious. So if you ever see one in a clinical setting, kind of approach with caution and leave it alone, unless you are doing something specific to it because you've been asked. So I wouldn't vena puncture from that arm. I wouldn't take blood pressure from that arm. You can see them. They are quite dilated. And once you feel them, you can feel that they've got kind of a pulsatile feeling. They've got like a thrill or a bruit. So if you do get a chance to, if you're lucky enough to get a chance to have a feel of one, I definitely would. So this hemodialysis is done over 3 times a week in hospital. And that's why this access is so important, because we need it all the time. So if you think how difficult it is to get blood from someone who has their veins accessed often, because they're getting recurrent blood tests, these patients need their really good access. And the alternative option is a kind of tunneled central line up in the neck, but the preferable, again, is via an arteriovenous fistula. Some of the complications firstly relate to the access itself, so whether or not you get thrombosis or stenosis of the access and then you can't do what you need to do. Secondly is that it might get infected, especially that's particularly talking about kind of those tunneled lines. Anything that comes from outside of the body into the body is a risk factor for infection. And thirdly is that it is time consuming. These patients do spend a long while of their week in the wards, but it does kind of allow them to have freedom and mobilise when they're not getting their dialysis done. So this is just a picture of the machine. So this is the arm here. Blood will come out of your fistula or from your central line and will come through this pump. Then you add a blood thinner so it doesn't get stuck. And then this is the dialyzer or artificial kidney. And this is your semi-permeable membrane. Dialysis fluid comes here, blood flows against it. All the bits that you didn't want in the blood have now come out, and then the good blood comes back and goes through into the arm, into the venous side. So have a recap of that if you want to later with the slides. Second option is peritoneal dialysis. The peritoneum is a semi-permeable membrane rather than that kind of one that's in that artificial kidney. So you're using your own body as your dialysis machine here. You infuse the fluid, as you can see, into the peritoneal space by a catheter. And the way you remove the excess fluid this time is by adding osmotic agents such as glucose. So fluid goes in to the peritoneal space, the peritoneum does the exchange, and then the stuff that you didn't want comes out into a waste bag. So this kind of happens more continually, and it happens at home. So it might give some like patient choice as to what they want. It might give them a bit more freedom if that's kind of the way they feel, if they don't want to spend a lot of their time in hospital. Complications are kind of site infection, hernia, so there's a weakness in that abdominal wall from where you put that catheter in. It's likely that you might get some bowel contents herniating out through that. A really kind of deathly complication of peritoneal dialysis is peritonitis, and that's where you get kind of infection. There's a lot of like rich fluid in here that the bugs really like to kind of stick to. So if that gets infected, the patients can become really sick. And another bad thing about this is that it does get less effective with time. So you might need to think about other options, but this is done at high level decisions with kind of the renal doctors and the patients and their families. So just having a brief idea about which one is which and how they kind of work is good enough typically. So finally, just one more bit about dialysis. Sometimes patients come in and they're acutely unwell, and there might be a reason that you might need to do it. And the acronym that I use for this is AEIOU, so acidosis and metabolic acidosis. E is electrolytes, so that's if your potassium is really high. Obviously, have a look at the acute protocol for hyperkalemia, because there are things you have to do as well. But if that's not being treated by those, then they will need to be dialysed to get that potassium out. Intoxicants, so these are the things that patients might ingest. And there's another acronym for this, which is SLIME, so salicylate. So if someone takes a kind of aspirin overdose or aspirin overdose, then they might need to be dialysed. Lithium, which is a mood stabilizer. Isopropanol and methanol are kind of non-drinkable forms of alcohol that people sometimes drink for different reasons. Those aren't very good for you either. And then ethylene glycol is antifreeze, so the thing that you put into your windscreen fluid. Fluid O is for overload, so fluid overload that you can't treat by diuretics. And U is uremia, so if a patient's got symptoms of uremia acutely, then we're thinking this is not good, we need to dialyze and the kidneys are not working. And finally, we've got one more case after this, but then we're nearly done. Just a bit about renal transplant. All patients heading towards renal failure should be considered. Some of the contraindications for this include metastatic cancer. That typically for any transplant is an absolute contraindication. Obviously, things do change patient to patient, but typically that means that people won't get a kidney transplant. Kind of temporary reason that someone might not be able to have it is because of infection, and then a relative contraindication is cardiovascular disease. Obviously, I've said that a lot of these patients will have that, but depending on the degree and kind of the outlook on this patient's kind of prognosis for expected life expectancy will depend whether or not they'll be eligible for a kidney. So it can be done with a deceased or a living donor. And immunosuppression is required in these patients so that you don't get kind of that rejection where your immune system attacks the graft that you've put in. Really good question for medical schools that I've seen come up fairly frequently is what are these patients that are on immunosuppression at more risk of? And the main thing that are more at risk of in terms of cancers is a squamous cell carcinoma, so that kind of medium skin cancer, so not the completely benign one and not the really malignant one. And then in terms of complications, whenever I think about surgical complications, typically if you're stuck in an OSCE, infection and bleeding tend to be fairly good ones to mention. And specifically for this surgery, you've got rejection or the fact that the graft might take a while to heal. And then if you want to just have a little look at the right, this big J-shaped scar here is called a Rutherford-Morrison scar, because sometimes surgeons like you to be able to name different scars. So if you see this in some sort of OSCE scenario or whatever kind of exams you have, it could mean that the patient has had a kidney transplant. And typically what happens when they implant a kidney is that they don't remove the one that is no longer working, so they will just add an extra kidney lower down in the ureter. So if you see this scar, I would palpate in the iliac fossa on the side that the scar is in, and you might be able to find an extra kidney. Okay, so just my final question, and then I'll get to all your questions. Thank you so much so far. So which one of the following is not an indication for acute dialysis? So I'll just get that poll up now for you. Sorry. Okay. I'll let you have a little read of that. So just a couple more seconds while more people have a chance to answer if they would like to. Okay, slow down a little bit, so I'll end that now and share the results. So when I think about that acute, the indication for acute dialysis, I think A, E, I, O, U. So just to recap those are acidosis, electrolyte disturbance, intoxicants, overload, so fluid overload, and uremia. So fluid overload falls into that category, as does acidosis, as does salicylate poisoning in the form of intoxicant, and as does uremia for the U. So jaundice is not an indication for acute kidney injury. It is something to do with the liver and won't necessarily be fixed by kind of dialysis. So yeah, that's the right answer. So you've done well there. So stop sharing that. And I think that's all I have. So if you've asked a question, feel free to stay on, and I'll try and get to that now. Just quickly, our takeaway message was to think about acute kidney injury and how we think about the causes into pre-renal and post-renal. We talked about how to treat acute kidney injury and how you have to treat the cause. We've talked about the fact that chronic kidney disease is not always going to hit you in the face as a clinician, and that when managing it, you must reduce the risk of cardiovascular disease. And then we've learned that there are two main types of dialysis, and that's peritoneal and haemodialysis. So thank you for listening. If you don't want to stay on for the questions, but I'm happy to go through them. Those are my references, and there's a picture of the feedback thing. So I'll just go through the questions. There's quite a few of them, so bear with me when I try my best. I'm sorry if I can't answer them all. Okay. So why do we give ACE inhibitors in patients with glomerulonephritis? I'm not necessarily sure that that is something you do. Typically, patients with glomerulonephritis are treated. That is typically a cause of acute kidney injury, which is something we wouldn't want to give ACE inhibitors for. Classically, the way you treat glomerulonephritis is by immune modulation, because the diseases that cause it are often to do with your immune system kind of attacking the kidneys. So I'm not particularly sure if my side said that you give ACE inhibitors in patients with glomerulonephritis, I do apologise. What I meant is you give them in patients with chronic kidney disease. If you've heard that source from somewhere else, I'm not particularly able to answer it, so I do apologise. I hope that has helped. Sorry. Okay, yeah, so can you explain the difference between acute tubular necrosis and acute interstitial nephritis? So, but I can't go back to this. Can I go back to the slides? It's quite far back, but I'll try and explain it. And if you want to have a re-look at the slides later, just that kind of renal causes of acute kidney injury. So acute tubular necrosis is what happens when the kidney has a prolonged period of not having enough perfusion. So the tubules will, as it says kind of on the tin, is the tubules will necrose. So anatomically that's slightly different. And to interstitial nephritis. Interstitial nephritis is inflammation between the tubules. So one of them is in the tube, one of them is to do with the tubules, and one of them is between the tubules. And then the causes, tubular necrosis is to do with prolonged hypoperfusion, and acute interstitial nephritis is to do with kind of drugs and agents that you give that can cause damage to the kidneys. So I hope that helps. So what is the difference between albumin and creatinine ratio, albumin creatinine ratio and protein creatinine ratio, and when would one be preferred over the other? So really good question. Albumin and creatinine ratio is kind of the gold standard when it comes to chronic kidney disease. It's just a kind of preferred marker. I'm sure there are reasons way beyond my understanding as to why you use the protein as a generic one. I've always been taught that albumin is used, and if you remember that graph that I put up earlier that had kind of albumin versus EGFR, those are the ones that you're using to kind of, they've got the data behind it, as far as I'm aware, for kind of what prognostically is going to happen to that patient. There might be other reasons, but typically I've always seen and been taught that albumin creatinine ratio at kind of my level is the one that you use if you can. It might be to do with the differences in labs and that kind of thing as well. So I hope that helps. So how can you distinguish between acute tubular necrosis and interstitial nephritis clinically? Can NSAIDs not cause both? Yes, so NSAIDs can cause change to the renal vasculature, which can cause them to be hypoperfused. The way you distinguish between them clinically is kind of by your investigation. That's where that kind of those renal doctors come in, that biopsy comes in. That's the best way, so they can see, they can check the histology and see what's been happening. It's slightly more difficult because it's obviously at a much smaller level than kind of our imaging allows at present. So biopsy is the way to go for that. How can you tell the difference between nephritis and vasculitis as a cause of hematuria? So again, that comes down to renal biopsy. That's the points at which you call the renal doctors and they have a look down the microscope, because they are really clever at looking and seeing what the causes are. And that will also be whether or not the systemic symptoms. Vasculitis can cause a glomerulonephritis, but the specific cause in kidneys typically tends to be by looking at a biopsy. So why do you get hypertension in glomerulonephritis, but not nephrotic syndrome? So I'm sorry if I wasn't particularly clear on this. Glomerulonephritis is the overarching term, and the two syndromes that come out of this are nephrotic and nephritic syndrome. So the reason that it's less so in nephrotic syndrome is because you've got protein loss and edema. Nothing to say that you're not going to get hypertension, but it's not one of the main hallmarks. You classically think about it in the triad, again, of low protein in the urine, edema, and low albumin in the blood. Again, so glomerulonephritis is split into nephrotic and nephritic syndrome. So what is the role of, I'll probably answer maybe 5 more of these and then kind of let you go. So what is the role of ACE inhibitors for CKD and AKI? So good question again. If you wanted to have a look up online, you can see what actually the ACE inhibitors do to the kidney. So they cause vasodilation of the efferent arteriole. So that is what we want in chronic kidney disease. That's a good thing. So they're good in chronic kidney disease, but in AKI, that means that they're not allowed to do the protective measure. So often the efferent arteriole vasoconstrict in acute kidney injury to increase the pressure in the glomerulus. And if you're giving a drug that stops them from doing that, the kidneys can't protect themselves. So chronic kidney disease, ACE inhibitors good. Acute kidney injury, ACE inhibitors bad. Hope that helps. How often are patients with chronic kidney disease screened to assess disease progression? So this is a really good question. I'll have an answer it now. So depending on how severe the disease is, so how much albumin is in their urine and how low their eGFR is, classically they're screened once a year, up until it kind of gets to a terminal point that they're thinking about. GPs might need help from a renal physician. Or if the situation is accelerating faster, you might check it every 6 months. But if you have a look back at the slides, it says kind of when to refer to renal. So if any of those reasons are happening, then you might want to check it more frequently. So typically a year, every year, if it's not that bad, and then 6 months if it is quite bad. I hope that helps. So how does having a nephrostomy increase your likelihood of acute kidney injury? I'm really sorry if that was confusing. It doesn't. It's a treatment for one of the reasons that you might have acute kidney injury. So Hydronephrosis can cause damage to your kidney, and that's why there's something blocking the way for the urine to get out of the ureter, so it pushes back into the kidney swells up and it can't do its job anymore because it's full of fluid. So a nephrostomy is a treatment for that. So you put a catheter in to allow the urine to drain out so the kidney can then function properly. So it's not necessarily a cause, it's more of a treatment. Okay, so I'll just do two more. So what is Bence-Jones proteins? They are a marker that you look for in the urine to see if a patient has a blood cancer called myeloma, because myeloma is a reason that people can have problems with their kidneys. I would recommend having a look at it up when you're kind of on your haematology rotations, as it can come up fairly often in medical school exams. I just wanted to put it in there as a touch to remember that myeloma is a reason that you might have a high creatinine. Okay, so why does a fistula look like a lump on the patient's arm? The reason this is because you get that kind of the side-to-side anastomosis of the artery to the vein. The artery has a high pressure under thick kind of musculature, and this transfers over to the vein and causes the vein to dilate and fill with blood at a high pressure. This means that it kind of swells up and becomes more visible. It is much more noticeable. I think one really important thing to comment is that for these patients with renal disease, they can often be quite self-conscious and their body image may be slightly skewed by this fistula, but these things are really important and allow them to have a really good quality of life. So it's kind of those human factors of treating patients and making sure that you're looking after a person of a whole. That's the medical reason, but patients will be really careful of their fistulas and might be a bit self-conscious when they first get one. It's important to celebrate the things that we can do for patients and make them feel as good as we can. Okay, so I think I'm going to leave that for answering questions because it's probably really late now, even though I can't access the clock. So I'd like to thank the Becoming a Doctor team for having me, and hopefully someone will come on now to say goodbye. But here's the kind of, here's the QR scan. If you would like to leave me some feedback, I'd be really grateful. Thank you for your time and thanks for listening.